Bismillah ar-Rahman ar-Rahim. I'm going to talk about gait patterns in unilateral cerebral palsy or CP hemiplegia. Cerebral palsy, unilateral involvement in patients with cerebral palsy is secondary to primary involvement of one side of the body, secondary to involvement of unilateral side of the brain. Sometimes the classification or differentiation between unilateral and bilateral is very difficult in severe cases, and most cases of unilateral cerebral palsy with severe involvement are really either severe form of asymmetric diplegia or mild form of quadriplegia. And sometimes the differentiation between unilateral and bilateral cases is very difficult. This injury or this pattern of involvement of cerebral palsy is secondary to injury of the one cerebral hemisphere. And this is, in majority of cases, is secondary to third trimester anterior cerebral artery occlusion or infarction. That's why sometimes we cannot find a relevant history of neonatal injury or neonatal insult or like hypoxia or incubator in these children. Most of the patients with unilateral cerebral palsy are highly functioning community ambulator, and most of them, they are gross motor function classification system, either 1 or 2. The minority are 3. Very rare to find pure or isolated unilateral involvement, and he is GMFCS level 4. We have 4 types, classic 4 types of gait pattern in unilateral cerebral palsy, according to Winter. Type 1 is foot drop. Type 2 is true equinus. The heel is not touching the ground. And this is secondary to either spasticity of the gastrocnemius, and this spasticity is dynamic spasticity. That's mean the child develop equinus once the toes touch the ground. Or secondary to contracture of the plantar flexor, either the gastrocnemius or soleus, or both. Type 3 is the same like type 2, but in addition, there is abnormality of the knee joint. These abnormalities either abnormality of the quadriceps muscles or abnormality of the hamstrings muscles. Type 4 is similar to type 3, but adding to it abnormality of the hip joint in the form of either adductor spasm or adductor shortening or iliopsoas shortening or contracture and flexion deformity of the hip. This classification has been modified a little bit to add 2 subcategories. Type 0, which is plantigrade foot in unilateral cerebral palsy, and type 2 has been subclassified. This type 2 is the true equinus, has been subclassified into type 2A, true equinus with straight knee, and type 2B, true equinus with recurvator knee. Let us see. Type 0. Type 0, a child with unilateral cerebral palsy, CP hemiplegia, and walking plantigrade. And this usually follow lengthening of the plantar flexor, either lengthening of the tendon Achilles or lengthening of the gastrocnemius. After this lengthening, there is weakness of the muscle, especially if the patient underwent aggressive lengthening. And this weakness will decrease power generation of the foot, and the patient depends upon the proximal muscles of the hip and knee for propulsion and for swinging of the foot and progression of the gait cycle. And if this patient has been operated upon early, they're liable to recurrence of the flexion of the shortening of the plantar flexor, and usually will need revision lengthening or another stage of lengthening of the plantar flexor after the age of 10 years. How to treat these patients? Just follow up and muscle strengthening, focusing on the plantar flexors and proper stretching of the hamstrings muscles to avoid the development of crouching and development of shortening of the hamstrings and flexion deformity of the knee. Sometimes we may use braces, but really the braces has the disadvantage of production of muscle weakness. So as long as we can, we shouldn't use braces in these children and leave them, and they will develop recurrence of the plantar flexor shortening, especially if they are young at the time of the original or the first surgical release. Type 1 is foot drop. That means there is no active dorsiflexion of the ankle, like this child. He has foot drop, dragging of the foot on the ground. He has his heel touched the ground completely. This means that there is no plantar flexor shortening. Another child, he has foot drop also, and dragging of the toes on the foot on the ground, but he has mild shortening of the plantar flexor, so the heel cannot touch the ground. It's very important to realize this foot drop, because even after doing release of the plantar flexor, the patient has to wear walking FO or ankle foot orthosis or orthosis to prevent this foot drop and provide the patient with heel contact during stance phase. So treatment of type 1, which is the foot drop, again, is by use of walking orthotics, either using of a rigid FO, posterior leaf spring, or hinged FO. Sometimes the hinged FO is used on the assumption that it will allow dorsiflexion and allow the stretch of the plantar flexor and prevent shortening of the plantar flexor, but really there is no publication that prove this or prove that hinged orthotics is superior to rigid orthotics or posterior leaf spring, except it is much expensive than the other two. The tibialis posterior transfer is not used for this type of foot drop, and usually tibialis posterior to anterior transfer is used in cases of common peroneal nerve palsy or flaccid paralysis, after proving that the tibialis posterior is functioning, well functioning, of good strength and phasic, to transfer it to the dorsum of the hand. But in cerebral palsy, this is not the case, and usually it is not used as a transfer to correct the foot drop. Type 2. Type 2 is true equinus. And this true equinus may be associated with straight knee during mid-stance or recurvatum knee during mid-stance. This is type 2A, which is true equinus with full knee extension during mid-stance. Another example, true equinus, and the child is able to fully extend the knee during the mid-stance. Sometimes these children walk with a contralateral normal side with equinus to compensate for the leg length discrepancy caused by the equinus on the diseased side. So examination is mandatory to exclude or the presence of contralateral or bilateral involvement in cases of asymmetric diplegia. Sometimes the child like this, look again, he is doing equinus on the contralateral normal side to equalize the length of the lower limb. And when you are asking the child to walk, he is trying to put his foot on the ground, and this will push the knee posteriorly. But in this case, even after this pushing, he cannot develop recurvatum of the knee. So this is type 2A CP hemiplegia. The shape of the foot in type 2 may be either plantigrade with planovalgus foot, or equinovalgus foot, or equinovarus foot. So this is a patient with cerebral palsy hemiplegia. He is walking with the feet on the ground, but really he has a mid-foot break and severe flat foot. And this flat foot and mid-foot break compensate for the shortening of the plantar flexor, and all the dorsiflexion of the foot that make it plantigrade is coming from the midfoot. Another form is the equinovalgus. The heel is in valgus, but the foot is in equinus. There is no severe midfoot break, or there is severe shortening of the plantar flexor that couldn't be masked by the midfoot break or the flat foot. And this is, it's not the common presentation in CP hemiplegia, but it is a common presentation in CP diplegia. The commonest presentation in CP hemiplegia is equinovarus deformity. This is the classic for equinus deformity or type 2 CP hemiplegia. Type 2B is equinus causing recurvatum of the knee, like this child, look, with prolonged equinus deformity, he developed severe recurvatum of the knee, and this is secondary to equinus deformity. It is not a pathology of the knee. Sometimes this develops after lengthening of the hamstring and missing plantar flexor contracture in these patients. To diagnose or to examine and properly assess the length of the plantar flexor, we have to fix the heel in neutral or mild varus posture during examination, because if the foot is in valgus, then the movement may come from the midfoot break and flexibility of the mid-tarsal joint. And this is what I mentioned before, that this midfoot break may mask equinus deformity, although there is shortening of the plantar flexor. And we have to do this Silver's coil test to differentiate between shortening of the gastrocnemius or shortening of the soleus or shortening of both. If we have shortening of the tendon Achilles, both gastrocnemius and soleus, then the equinus does not correct with flexion of the knee. But if it is shortening only of the gastrocnemius, then there is correction of the deformity, and dorsiflexion could be achieved with flexion of the knee. Look here how I'm doing the Silver's coil test. I'm fixing the calcaneus in neutral position and testing the dorsiflexion of the foot with knee flexion and knee extension. In this case, I can achieve good dorsiflexion with knee flexion. That means the shortening is mainly in the gastrocnemius and not in the soleus. The treatment of type 2, if the patient can use ankle-foot orthosis and can achieve plantigrade walking with ankle-foot orthosis, so then we can use ankle-foot orthosis to improve gait. And we shouldn't use it for whole day walking. It should be used as a part-time walking exercises, because it will produce some weakness of the muscle, and it's not the aim. Botulinum toxin may be injected in the calf muscle, and it is used only in dynamic deformities and when the patient cannot tolerate orthotics. So the main indication is if the patient cannot tolerate orthotics. But if the patient can tolerate orthotics and there is dynamic deformity and no true shortening of the plantar flexors, in these cases, there is no indication for use of botulinum toxin. Surgery is the final treatment for shortening of the plantar flexor, and we have to target the shortened muscle. If there is shortening of the gastrocnemius, we have to lengthen only the gastrocnemius. If we have shortening of the soleus and gastrocnemius, then we have to lengthen the tendon Achilles. The earlier the first intervention, the multiple the recurrences. And we have to tell this to the patient. And once we operate before the age of 8 or 7 years, we know that the patient will need another surgical intervention after the age of 10. So If we have mild deformities and mild equinus deformity, in a young child, we have to wait and not to hurry up for releasing of the plantar flexor, because repeated surgery will produce long-lasting weakness of the plantar flexors. If we are going to release the gastrocnemius, we palpate the muscle, and by palpation, we find the site of the musculotendinous junction, usually at the mid of the calf muscle. Then we use an incision about 3 centimeters, expose the aponeurosis of the plantar flexors, and then do release. Sometimes when we are doing a higher level of release, we can release also, in addition to the gastrocnemius, the soleus fascia. And the higher the level of release, the less the release. So if we go much more proximal, the less the release of the plantar flexor. When we go more distal, the higher the degree of release of the plantar flexors. Then here we release the gastrocnemius fascia. If we are going to release the tendo Achilles, we can do it percutaneous in hemiplegic patients. And we have to understand the anatomy of the plantar of the tendo Achilles. The fibers of the tendo Achilles are rotated 90 degrees. So the the medial fibers become dorsal distally, and the lateral fibers proximally become anterior distally. So if we want to cut the whole fibers, we can cut anteriorly, the anterior 2/3 of the tendon above its insertion, about 1 centimeter, and then cut the medial half or 2/3 proximally. So by these two cuts, we cut two different parts of the fibers of the tendo Achilles. So the tendo Achilles will slide on itself and will produce lengthening of the tendo Achilles. This is how we do it above the insertion, and then we cut the anterior 2/3, and then palpate the tendon and cut the medial 2/3 proximally, and then do forced dorsiflexion, and we will have lengthening of the tendo Achilles. We have to palpate and ensure that the tendo Achilles is preserved and it is intact. The patient is put in a walking cast, either gastrocnemius or soleus, walking cast for 3 weeks. And after that, we remove the cast. This is the patient with true equinus deformity. There is no abnormality of the knee. He can achieve full knee extension in mid stance. And this is after release. He can walk plantigrade very, very nicely. The patient has to keep on stretching exercise or range of motion exercise, may use night splinting in case of tendo Achilles to stretch the plantar flexors, but there is no proof that this will delay or prevent the development of secondary contracture if the patient has been operated earlier in life. Sometimes the patient comes with neglected equinus deformity and have severe flexion, plantar flexion deformity, and severe equinus and severe shortening of the plantar flexors. And in these cases, the tibialis anterior are overstretched. If the patient is younger than 10 years after releasing the plantar flexor, the tibialis anterior may regain its power and regain the power of dorsiflexion of the ankle. But in patients more than 10 years, usually this takes a long time, sometimes 1 or 2 years for the tibialis anterior to regain its length and to regain its power. In these cases, it's advised to do tibialis anterior shortening in addition to the plantar flexor release. I have never tried it, but it is mentioned in the recent literature. In severe neglected equinus deformity and the patient is older in age with rigid equinus, we may do, in addition to the plantar flex release plantar fascia. Release may require a long flexor release of the toes flexors and tibialis anterior shortening, as I mentioned before. Ankle joint capsulotomy is not needed in these cases. Shouldn't be treated like cases of neglected or missed clubfoot or treated it as surgical treatment of clubfoot. As I told you, the patient may have, in addition to this, the Equinus deformity, varus deformity. And this varus may be secondary to tibialis anterior dysfunction or shortening, or tibialis anterior abnormality, like overactivity and dynamic supination deformity. This is an example of a child with CP hemiplegia with fixed equinus throughout the stance phase and throughout the swing phase. In this case, it's mostly a tibialis posterior problem. And in this patient, we did tender Achilles lengthening to address the equinus deformity and split tibialis posterior transfer to correct the varus deformity. And postoperatively, she has a very nice plantigrade foot with correction of the varus deformity. Sometimes, especially in hemiplegic, we may do only release of the tibialis anterior, and there is no proof that transfer is superior to only release of the tibialis posterior. This is another girl with varus deformity, but she has, in addition to the fixed varus of the heel, dynamic supination, dynamic over supination of the foot. And in this case, we did tender Achilles lengthening for the equinus and tibialis posterior release and split tibialis anterior transfer to correct the dynamic supination. And postoperatively, she developed a very nice correction of her foot. It's become plantigrade, the heel in valgus, and there is no dynamic supination of the forefoots. In rigid deformity and rigid varus deformity, like this guy, in this case, tibialis anterior release is not enough for correction of this rigid varus deformity of the heel. And in this case, we did tibialis posterior release, tender Achilles lengthening, and lateral sliding calcaneal osteotomy to correct the fixed deformity of the heel. And after surgery, he developed a good plantigrade foot. He's not a classic type 2, by the way. This patient is 28 years old with very rigid equinovarus deformity of the foot. And in this case, it couldn't be corrected with surgical release or lateral sliding calcaneal osteotomy, and the heel and the deformity is very rigid and severe. In this case, we shifted to correction of the equinovarus deformity by Elizarov, followed by plantar release and tibialis posterior release, and she achieved a plantigrade foot after this surgery. These cases are uncommon because most of the patients are treated earlier. And if this patient receives the proper treatment earlier, she will not, she wouldn't go in such rigid deformity and will not require such aggressive intervention. What are the results of plantar flexor release? Recurrence in 25% of cases. The earlier the intervention, the higher the rate of recurrence. The severity of the equinus and shortening of the plantar flexors indicate that there is a higher incidence of recurrence. And so we have to warn the parents that if we did surgery early, they will have a repeat recurrence, and they have to stick to night splinting and daily stretching exercise to try to prevent as much as we can the recurrence of the deformity and the need for another surgical intervention. But we have to keep in mind that to have a multiple recurrence is much, much better than having over-lengthening of the tender Achilles and decrease the power generation of the foot. And this is very uncommon in hemiplegia patients, but it is very, very important in diplegic patient because diplegic patients have very high liability to develop early over-lengthening of the plantar flexors and to develop crouching. Type 3. Type 3 is the same type like type 2. There is shortening of the plantar flexors, but in addition, there is abnormality of the knee joint or the muscles around the knee joint. So it is either the hamstring causing flexion deformity or the quadriceps causing stiff knee gait. This is the flexion deformity. Look, the child cannot achieve full knee extension in mid-stance. In mid-stance, the knee is flexed in addition to the equinus deformity. This is another example. Look, it is jumper gait. It is unilateral jumper gait. Jumper gait, the knee is flexed and there is equinus deformity and the child cannot achieve full knee extension. This is in contrary to type 2 with the patient in equinus but can achieve full knee extension in mid-stance phase. In this case, it's treated straightforward like type 2, but in addition, we shouldn't miss the abnormality of the hamstrings or if there is fixed flexion deformity of the knee. And the fixed flexion deformity of the knee is present when we cannot achieve full knee extension with the hip extended. But if we can achieve full knee flexion with the hip extended and there is shortening of the plantar flexor, then we have a high popliteal angle. And in this case, we have to do hamstring release. And if there is fixed flexion deformity, then we have to do supracondylar femoral extension osteotomy. This is detailed in the lecture for diplegic patient. Look, this patient has type 3 hemiplegia, and we did for him plantar flexor release and hamstrings release. If we missed the hamstring in this patient, or we did only hamstring in this patient will develop knee recurvatum deformity. And if we did tendo-Achilles lengthening without hamstring release, this patient will develop severe unilateral crouching and very ugly gait, and this will produce early recurrence of the plantar flexor shortening and contracture. The other form of type 3 is equinus with stiff knee gait. Look at this child. He has stiff knee gait. He has no flexion of the knee during swing. The knee is stiff. He walk with circumduction gait. He do plantar flexion, excessive plantar flexion in the contralateral side to clear the foot and to transfer the diseased foot and do swinging of the diseased foot. In the majority of these patients, the cause is rectus femoris overactivity or rectus femoris shortening, and we can diagnose this by doing the Duncan-Ely test, by making the child, put the child prone and then do flexion of the knee. If the glutei pop up, this means there is shortening of the plantar flexor. If this popping occurs with rapid flexion of the knee and come back again to its place, then this means spasticity and overactivity of the rectus femoris muscle. And to be sure that the rectus femoris is the cause of this stiff knee gait and this stiff knee gait is not secondary to other pathologies, we have to do 3D gait analysis. And it is characteristically to find that there is the reduced peak knee flexion. The knee flexion should be around, during the swing phase, should be around 40 to 50 degrees, then it is low. And there is delayed peak of knee flexion, and there is reduced total arc of motion of the knee and range of motion of the knee during swing phase. When we find this, in addition to firing of the continuous firing of the rectus femoris, we know that this is a pathology of the rectus femoris, and the treatment on these cases is to transfer the rectus femoris. Transfer whatever you like. it will not be a flexor of the knee, but transfer is to prevent recurrence of the deformity, because release only has the same effect as transfer during the first year after surgery, but have a high rate of recurrence of stiff knee gait because the muscle reattach again. The last type is type 4. It is a type 3 with abnormality of the knee. In addition, there is abnormality of the hip joint. Either this is inferred from the presence of adduction deformity, spasticity, or shortening of the adductor muscle, or and flexion deformity of the hip. And usually type 4 is not a pure or isolated form of hemiplegia. Usually it is a part of diplegia or mild form of quadriplegia. And sometimes it's very difficult to differentiate these types. Usually type 4 is associated with rotational deformities. And sometimes these rotation deformities produce side walking like this girl, and has to be, and this rotational deformity has to be addressed in addition to soft tissue release. Another example, look at the unstable gait pattern in this boy. This is not an isolated form of hemiplegia, but because of the clear asymmetry, we can call it type 4 hemiplegia. This is another example of type 4 hemiplegia, but really it is a part of mild form of quadriplegia or asymmetric form of diplegia. Type 4, it is relatively uncommon to have a child with pure or isolated type 4 hemiplegia, who is normally on the contralateral side. And this patient liable to develop spastic hip disease and liable to develop hip dislocation. And this is the commonest cause of hip dislocation in ambulator cerebral palsy. We know that hip dislocation usually, or hip spastic hip disease, develop in non-ambulator. But this is the only exception, that patient with type 4 hemiplegia may develop spastic hip disease and hip dislocation in spite of being ambulator. They have a high incidence of rotational deformities and high incidence of leg length discrepancy. And the treatment is single event multi-level surgery. And we have to avoid iliopsoas lengthening if the hamstring release is not required, because this may produce severe deformity of the hip and decrease propulsion and flexion of the hip during swing. And we shouldn't do adductor release if we have about 20 degrees of abduction of the hip and the hip is abducted during mid-stance phase. And in this patient, because they stand with adduction deformity of the hip in the disease side, the adduction will increase the leg length discrepancy. What is the story of leg length discrepancy in CP hemiplegia? Usually in type 1, 2, and 3, the discrepancy is about 1 to 2 centimeters. And this discrepancy, shortening of the disease side, help clearance of the foot and shouldn't be corrected, because it's helpful for the patient to clear the diseased foot and do swinging of the lower limb. But in type 4, because the contralateral side is not healthy, and there is weakness and weak stability on the contralateral side and the excessive shortening, then it is very difficult to clear this side of the ground when standing on the short diseased lower limb. And this is the only situation that sometimes we need over lengthening of the disease side by about 1 centimeter to help clearing the less affected side of the lower limb. So in unilateral cerebral palsy, the higher the grade and the classification of the pattern of walking in this patient, the higher the age of walking. Usually type 1, 2, and 3 walk early, before the age of 2 years, and 3 and 4 walk later after the age of 2, sometimes 3 years in type 4. The higher the gait, the higher the number of the gait pattern, the higher the gross motor function classification system. So 3, and very rare to find 4 in type 4 hemiplegia. The higher the grade, the higher the rotational deformities, and the higher the degree of shortening. Thank you.